So here you are watching Coblation suspension bridge pharyngoplasty in a 37-year-old male with BMI of 28 and AHI which is not been able to be done because he cannot tolerate a sleep study ever. I have already done his septoplasty, turnoplasty. He is much better with that, but he is snoring and is choking and he cannot even do a sleep study in the night because he is unable to sleep. On the dice, he has got both AP as well as lateral collapse, and he has also got a primary epiglottic collapse. That is one reason he is unable to tolerate CPAP. So I'm in this sitting, I'm going to perform uvulopalatopharyngoplasty and glossoepiglottoplexy. I'm starting with uvulopalatopharyngoplasty. We have taken consent for removal of the soft palate in the uvula because, as you can see, this uvula is pretty long, and this is the line joining anterior pillar to anterior pillar. Because I have already done the nasal surgery and I want to do the glossoepiglottoplexy, therefore the ventilation tube is from the nostril and I cannot show you where it's going and touching at the back. But if you see it, it's actually going and touching above this line joining anterior pillar to anterior pillar. So I will resect the soft palate. Many people trim the uvula here. It is of no use. Trimming it here is also of no use. If you have to remove, you have to remove it in the line joining the summit of anterior pillar to the summit of anterior pillar. I call the Agrawal's line. And if you remove the soft palate in this line, you will never overdo because the levator palati muscle will always remain here. This is the level of the palatoglossus. This is the palatopharyngeus. The levator palati will always be above this, and this is the area which goes and touches at the back to cause snoring and sleep apnea. So the moment you remove the soft palate in this line, obviously you cannot this work with cautery. You have to do this work with ablation mode of coblation at the setting of 7. You can do it at setting of 8 and 9, but if there's bleeding, you'll have to coagulate. So at a setting of 7, the chances of you requiring a coagulation is very less. And as you see, here I have reached the muscular layer and I am still below the level of these are the fibers of the palatoglossus. The levator palati will be still above. And when I go here, I will now see the fibers of the palatopharyngeus. Alright. So you can perform a tonsillectomy first, or you can do the soft palate work. I usually perform the tonsillectomy first. I did it this way as a variation today so that you understand the palatal muscles in great detail. And now, as you see, these are the vertical muscles of the musculus uvuli. This is the muscle, this is the fiber of the palatopharyngeus. So I'm only going through the muscles of the musculus uvuli, and you can see these vertical fibers. I'm going through the soft tissues, I'm going through the fibers of the palatopharyngeus here, and you can see the mucosa already reached. So I will stop at the mucosa. I'll try to preserve as much mucosa as possible. You can see this. I'm trying to preserve as much mucosa as possible at the pharyngeal aspect. And this is my take on the AP collapse. So the anteroposterior collapse starts here and the lateral collapse is in this region. So he has both AP as well as lateral. So see, even without doing a tonsillectomy, you can still take care of the AP collapse. What I'm doing here is preserving all the mucosa. Now I'm cutting through the fibers of the palatopharyngeus. These are the arching fibers of the palatopharyngeus. But I cannot see and cutting the mucosa very sharply, I cannot see the vertical fibers unless I remove the tonsils. As I said, I normally do a tonsillectomy first. Today is a variation, it's a different way of seeing this. And still, even without tonsillectomy, you can see the anteroposterior collapse has been almost completely taken care of. Now I am dividing it here. I will perform a tonsillectomy now, as I said, as a variation. I'll come to the left side and do a complete work on the left. Next, let me perform tonsillectomy, which normally is the first step of the surgery. Now, what I'm showing is a hybrid tonsillectomy. Now, see, the tonsil was not looking very large, but the moment you pull the tonsil, see how large is the tonsil. And therefore, you cannot start here. You have to start here at the lateral border of the tonsil. And I am dividing a few fibers of the palatoglossus muscle so that I can reach the lateral most extent of the tonsil. Alright, now see, this is the lateral extent of the tonsil. So I was using a tooth forceps till now. Now I'll take a lux forceps to pull the tonsil completely medially. And here I'll reach lateral to the tonsil. So unless you reach lateral to the tonsil, you'll not get into the correct plane. Alright, so pulling the tonsil medially, you see I'm trying not to open up the muscles unnecessarily. But I have divided some fibers of the palatoglossus. Now I'm pulling out the tonsil and you can see how large the tonsil actually was inside the pillars. So if you thought it was a grade 1 tonsil, it is actually a grade 3 tonsil. But it was hidden behind the pillars. That's where it causes more obstruction at the back. Alright, you see the muscles are not yet exposed at all. And therefore the pain will be minimal even when I am performing an extracapsular tonsillectomy. The small blood vessels I am coagulating so that they do not open later. And as I reach the inferior pole of the tonsil, which I have not yet reached, once I reach the lower pole of the tonsil, then I will go intracapsular. That's the hybrid tonsillectomy technique, especially for sleep apnea patients. Because what happens is that the tonsillar artery will come somewhere here. If you hit the tonsillar artery, then it can bleed later on. But if you go intracapsular, now see, this is the capsule of the tonsil. I am going intracapsular over here. Can you see? Here I have gone just a little intracapsular. So what will happen is that I will not hit the tonsillar artery directly. I will open up those branches of the tonsillar artery. This is extracapsular. This is extracapsular. And here I go intracapsular. I do not leave behind a lot of tissues, very little amount of tissue, only to make sure that you do not hit the tonsillar artery directly. I am coagulating along the course of the artery here anyways. So sequential coagulation has been done and still I am going a little bit intracapsular without leaving any significant amount of lymphoid tissue so that the bleeding in the post-operative uh, you know days do not remain a big issue because the caliber of the arteries The moment they enter the tonsil and divide into 2, 3, becomes very less. Now you see, can you see this? This is the last bit of the tonsil. This is the lingual tonsil here. So I do not want to leave any significant amount of tonsil tissue. I'm coagulating almost every bit of it, or ablating when required. Now see, I have ablated. I have not left any lymphoid tissue over there, but at the same time here I have gone a little bit intracapsular. So this is the lymphoid tissue. I have gone little bit intracapsular. Now see, this is the lymphoid tissue which I have left behind and coagulated. So that's not even a millimeter or so. If you leave this whole thing behind, then obviously it will act as a tonsil tag and give trouble later on. But you do not leave behind any significant amount of tissues. Idea is only to prevent the exposure of the main trunk of the tonsillar artery. Now this is again extracapsular. Alright, so you see there's a very small sliver of tissue which is coagulated, which is left behind on the tonsillar artery area, and that will help prevent any bleeding later on. Now let me see, have I opened it completely or not? Now see, this is the palatopharyngeus, this is the palatopharyngeus. There are still some fibers of the palatopharyngeus. These are the oblique fibers, these are the vertical fibers. So I am coagulating on the vertical fibers. I am not cutting on the vertical fibers. I am coagulating on the vertical fibers so that they will first of all fibrose. I am cutting completely on the oblique fibers. There are still some fibers pending which were hidden behind the tonsil. I am cutting on the all the oblique fibers of the palatopharyngeus. This is for lateral collapse. This is for AP collapse. Alright, can you see how much of the soft palate has opened up? Now this was the anterior wall of the pharynx, which is now being made the lateral wall of the pharynx. That's transposition of the pharyngeal wall. And what I'll do is, let me see if I can cut a little more. Alright, see, I have divided the oblique fibers completely, right? Before doing tonsillectomy, it was only this. Now I have been able to divide all these fibers extra, and this is the vertical fiber. Now I am still trying to divide all the AP fibers, oblique fibers. Now these are vertical fibers. Now I'll close the fossa like this. So what it will do, can you put the camera straight? Little more, little more. On. Thank you. Now what I'll do, we'll go to the pterygomandibular raphe. We'll take vicryl suture. So where is the raphe? The raphe is here between the maxilla and the mandible. We'll take vicryl suture, 2O round body, and this is the raphe. So we'll start lateral to the raphe, come in the supratonsillar area along the anterior pillar. So I'm not going into the tonsillar fossa, because if you do that, there's a chance that you open up the vessel inside. If you come along the anterior pillar, the chances of opening up the vessel becomes very, very less. So now, for complete taking care of the complete lateral collapse, we definitely can have more suturing in this area. But what I'm doing is I have already coagulated the vertical fibers, and the oblique fibers I'm, you know, taking laterally like this. So it will close the entire thing. It will splint the lateral wall also. Now, full thickness of the posterior pillar. I'm using full thickness of the posterior pillar so that it can be turned or transposed laterally. See, this is how its action will be. All right. So it will splint the whole lateral pharyngeal wall. Many people cut this at the bottom. Why I don't cut it at the bottom? Because if you cut it at the bottom, the chances of bleeding is more because the blood supply of this muscle is from the bottom. So I cut it at the top because this is the area which I want to take laterally, and get helps me getting a better lateralization. Now we'll take one more loop, kind of a figure of 8. This time from bottom up, I'm coming just outside in the mucosa. Can you see this? All right. So now what I want this, I want it to turn laterally and remain like this. And there will be no pressure on this. If you keep pressure, it doesn't work. So I'll just coagulate a little more on the lateral aspect. This is the supratonsillar area. This is the area where you have maximum. I'm just coagulating a little more in this area so that the lateral collapse maximizes, the lateral collapse minimizes. The whole pharyngeal wall becomes more stiff, and there is no blood vessel which can open up later on and create bleeding. It will help in both. All right. All right. Now I'll take the Vikas suture back from. This is the solution for the lateral collapse that I'm doing now. Tonsillectomy definitely will help now. I'm coming back from the same, almost the same point, but while coming back, I will stop before the pterygomandibular raphe. So this is vicryl suture. So this will go away in 15 to 20 days. I need a, yeah. So now see, this is the raphe. This time I'm coming out medial to the raphe. So the whole strength of the raphe will be made use of. But while pulling, I'll be very gentle. I'm not pulling it very hard. So what I'm doing is I'm only gently, very gentle pull. Now see this. Can you see the space? There's a lot of space between the suture here. It's not tensed at all. It's only directed laterally. All right. No force. Can you correct? Now see, there's a lot of space. Uh, so there's no force. The second stitch is being made a little tight, and the third one will be made absolutely tight. And I'll cut it little long so that it doesn't open up. All right. So I'll cut it a little long, some forceps, so that it doesn't open up. Now this will keep the flap laterally and you can see the difference already made as compared to the left side. Can you remove your phone? Now see this. The posterior pillar was like this and it's totally vertical over here. And here I need to make it like this. So now I'll take the barbed suture for the AP collapse. The barbed suture I'm going to use is a V-lock 30 non-absorbable barbed suture, which we started using first time um, in the world in 2019, I believe. But this is only used for the AP collapse. We are not using for lateral collapse because there's a lot of in the lateral collapse, there are a lot of visual sutures. You cannot do this with a non-absorbable. Now this is for AP collapse because this will still keep on collapsing a little bit. To prevent that collapse, I'll again start around 7-8 millimeter lateral to the raphe. So the raphe is here. I'll start almost 7-8 millimeter lateral. We'll go to the supratonsillar area. This is purely for the AP collapse. Now, if you can see the loop has to be completely buried inside, and therefore that 7-8 millimeter lateral starting, now it has gone completely buried inside and still sitting on the pterygomandibular raphe. So it's making use of the pterygomandibular raphe. Now the second, this has come out here. You have to go 1 or 2 millimeter proximal and then come out, go very deep and come out on the other side of the midline. Now this is the most important part of the stitch because, can you see this? This is going to pull this soft palate anteriorly. Why it will pull the soft palate anteriorly? Because the pterygomandibular raphe itself is anterior to the soft palate. So I think I have gone a little too far. I'll pull it out a little bit and then try to come out again. But it has to come in the correct place. You take your time, assess yourself. Now see, it has come out here. I want it to come out a little more into the mucosa, little more superior. Doesn't matter. So we need it. Yeah, it's almost at the correct place. Can you see this? So when you take the stitch, the net result is that now the soft palate is pulled anteriorly. So I'll go to the left side. I will finish off this suture first and then I do the tonsillectomy and do the lateral part. So I'll first take it out of the left pterygomandibular raphe. Can you pull the left pterygomandibular raphe? Alright, so raphe is here. As I said, there's a variation. I have not done the tonsillectomy. This is the raphe. I have to go lateral to the raphe. So I have to reach lateral to the raphe. If I cannot reach in one go, I will come out and go in again. But if I can, now see, this is the raphe. I am lateral to the raphe. Remaining lateral is most important because then only you can get the correct pull. Now let me perform the tonsillectomy and then I'll go back with the from left to right. Let me finish off the work. Coblation, please. One sec. Leave it. I'm just readjusting the tongue depressor, the mouth gag. All right. That's okay. Now see, again, this is the posterior pillar, the palatopharyngeus, this is the palatoglossus. And we know that the tonsil is looking very small, but it actually not be very small. So we start the dissection. You can adjust, focus it if you want. Alright, so this is the anterior pillar. I want to take a small bit of the anterior pillar so that I can get lateral to the tonsil. I know that the tonsil is endophytic in this case. You see how big is the tonsil? This is ending here. Therefore, I took that little bit of anterior pillar. In any case, this is the area where the collapse happens. So it helps to coagulate this area to make it more stiff. It doesn't harm at all. And you will see that in most of the techniques, they remove the supratonsillar pad of fat and rotate the palatopharyngeus laterally from there. Alright. So see how much of space is actually created. Now give me the lux forceps. So see here, we have not opened up the muscle. That's the anterior pillar muscle which I had divided. Just making sure that there is no blood vessel which can open up later on. You can see the paratonsillar vein, I am coagulating it. Coagulated the paratonsillar vein very nicely so that it doesn't open later on. That's the palatopharyngeus. Again, some small vessel. Coagulate that vessel so that it doesn't bleed later on. Anyway, and you saw this. There's another vessel, another set of paratonsillar vein, or maybe the main paratonsillar vein. Can you see this? It has to be coagulated very nicely. Once you coagulate the paratonsillar vein nicely, it's a low pressure system, so it will not open up later on. Alright, now remaining as close to the tonsil as possible. Alright, so the lower pole is still away. This was the paratonsillar vein which I have coagulated very nicely. Can you see this? That's the vein. I would have liked it not to even exposed. But in an extracapsular tonsil, you cannot have that luxury every time. Now, this is the lower pole of the tonsil. So, the tonsillar artery should come somewhere here where I am operating right now. In that area, I will possibly go intracapsular. Let me see. This is not the lower pole anyways. As I said, I do not want to expose the tonsillar artery. Venous system is still alright. So I've started going intracapsular already here. That's the hybrid tonsillectomy, which I've been doing for the last 10 years or so and has given consistent result in terms of bleeding. You save on bleeding if you go intracapsular because the tonsillar artery is not opened up directly. So what I'm doing here, I'm going a little intracapsular, maybe just a millimeter or so, not leaving too much of tissues behind. And you can see I'm even removing that tissue later on, only so that I do not damage the main trunk of the tonsillar artery. And the second thing is also that if you remove this whole tissue, the retrolingual space tends to reduce later on. So if you leave behind a very little amount of lymphoid tissue, the fibrosis in that area is much lesser and the reduction of retrolingual space does not happen to that extent. And anyway, this area is not contributing to sleep apnea. The upper pole of the tonsil is where the collapse happens. You do not need to remove every bit of lymphoid tissue in this area. Anyways, all right. You see, I have not left a lot of lymphoid tissues behind. I've gone till the last millimeter, and I'll coagulate this. So this tissue cannot hypertrophy again and give symptoms. But at the same time, the chances of a secondary bleeding would be absolutely minimal. Now I come back to my extracapsular. All right. Now this is extracapsular. And as I said, you could see this vessel of the posterior pillar. So the supply of the posterior pillar, can you focus it better? This area, can you focus? Yeah, focus. So this is the supply of the posterior pillar. So as I said earlier, if you try to cut this, release it here and try to pull this part like this, what you will save is the complete mucosa. What I am doing here, I am not cutting at the lower end, I am cutting it at the upper end. So let me coagulate, that's the paratonsillar vein, a large paratonsillar vein. We have to be very, very careful about this vein. There's one more here, one more here. All these venous plexus, if you coagulate, now I'm coagulating the vertical part of the palatopharyngeus, which causes your lateral collapse. I'm just coagulating there so that this part becomes more stiff and it does not contribute to lateral collapse. Anyway, the tonsil was a major region and the upper pole of the tonsil is out, so that will also help in preventing the lateral collapse. Now see, major part of the anterior posterior collapse was in form of the uvula, which has been removed. The lateral part of the AP collapse is because of these oblique fibers. Can you see this? What my aim is, rather than pulling it like this, I am simply cutting it here. What it helps is, it helps to open up the airway to the maximum. But as I said, you cannot cut it with cautery. You have to cut it with coblation and that too ablation. Do not coagulate in this area. Can you see? So I will open it up as much as possible, right? And preserving all the mucosa, all the oblique fibers of the palatopharyngeus I am cutting. And when I reach the vertical fibers, I'll stop. And I'm coagulating that area, that's it. So there will be no raw area created here. And I'll simply transpose this one laterally to form it the lateral border. Give me the vicryl suture, please. Can you put the tongue depressor, retractor, please? All right. Now see, this is the pterygomandibular raphe. So this was my non-absorbable suture. This is the vicryl. I start lateral to the raphe along the anterior pillar into the upper pole of the tonsil, and you see there is very less or almost no bleeding. Chances are very less that you will hit a vessel. Again, full thickness of the palatopharyngeus. Can you see? I have to make sure that I do not hit the paratonsillar vein. Taken full thickness of the palatopharyngeus right from the top to the bottom. So this whole muscle would be pulled laterally. You can always hit a small vessel, but that's nothing to worry. You can coagulate and proceed. Now I'll take again a full thickness suture, this time towards the upper pole and coming out of the mucosa. Why? Because I want this to face laterally. Alright? And very gently you pull it laterally. There's no need to put pressure on it. If you put pressure, it will not work. Again, coming along the anterior pillar, I'll stop medial to the pterygomandibular raphe this time and take simple knot on the, not on the barbed suture obviously, on the vicryl. Alright, let it be here, we'll see it later. Let's first take care of the vicryl. It is only to hitch, no pressures required, and Dr. Patel will now very gently, see there's still, okay, can you step it? No, you have got only one. Yes, step the knot. Perfect. Now the knot is stepped. Are you sure you stopped? Yeah, yeah, it's fine. It's fine. It's fine. So now I will, the second one I'll make a little tight. Second one is a little tight, and the third one will be absolutely tight so that it does not open up in the post-operative period. No, no, remain in place. Don't move. So the third one I have made very, very tight. Now we'll just cut it off a little longer so that it doesn't open up. All right, you can come out. Now we'll go for our completion of the. Uh, I can remove it if you want. Leave it. Yeah, I'll put it again. All right. Now we'll go towards the right pterygomandibular raphe. We'll take our barb. This is an end-to-end suspension bridge, both for anteroposterior as well as lateral. Now we had come from right to left. I'll go from left to right now. Because it's a non-absorbable suture, you have to give it time. Should not go any wrong place because you cannot remove it. Once it is in, it will last for life. Alright, so you have to come out in the correct place. This is for anteroposterior collapse. Alright, and one or 2 millimeter proximal to the exit. Can I have some? You do not have to make it very tight. Alright, but go very, very deep. Alright, across the midline. We only want the suture to prevent a AP collapse, both of the soft palate and of the tongue. This will also support the tongue. Again, a millimeter or two proximal, not distal. I don't think I can reach the pterygomandibular raphe in one go. Let me see if I can. Almost, yeah. So I can negotiate. I have gone beyond the raphe. Perfect. All right. Now we can simply cut it off over here. But what we can also do is to just take a U-turn and then cut it off. So it will further make sure that the barb suture and that U-turn can be in any direction, but has to be very, very deep. It cannot be superficial because it's a non-absorbable. Alright, now give me the suture. Scissor, sorry, scissor. So push it inside and cut it very, very near to the surface. Now you can see what is the net effect of this surgery is that both anteroposterior and lateral, if you want, you can put another vical suture over here to close. But that really doesn't matter because as long as this suture will last for 15 to 20 days, it will heal in this direction only. If you want, you can put additional suture. Doesn't matter. Now, the net effect of this surgery is that you can see how much is the anteroposterior diameter opened up, and it is further augmented by the barbed suture. Now, it cannot fall behind. And laterally, this lateral wall is now supplemented with this wall which is transposed laterally. This was the AP collapse which has been transposed laterally. This will become more less pliable, more stiff because of this lateralization. And since you have done minimally over there, so the pain will be also not very high. So this is suspension bridge, and the final thing is that when this suspension bridge, when the tongue rests over this soft palate, this will also be supported by the tongue also will be supported by the suspension bridge suture. So thank you for watching. I think we have to still do glossoepiglottoplexy. So let me stop here. I'll come back for glossoepiglottoplexy.